So let me know when I'm going to share the screen.
Yeah, so Vijay, Neeraj will let us know. Once his
Yeah.
sharing starts, then he will introduce you and then we will start. Okay?
Okay, great.
So, Viral Jain, you will have to start your video at least now.
Okay.
We are live now. So, good evening, everyone. Welcome to this IFICS Ortho TV PDORTH tutorials. And over to Dr. Taral Nagda to take over the session.
Absolutely. So welcome everyone to the fifth session of IFICS tutorials. IFICS tutorials are one more presentation for International Fractures in Children Symposium. This is a baby conceived by 3 pediatric orthopedic surgeons, Sandeep Patwardhan from Pune, Taral Nagda from Bombay, and Premal Naik from Ahmedabad. So during COVID time, we've started this postgraduate teaching activity where we have basic topics taught in a basic manner, which are well understood by postgraduate residents and fellows. And in the fifth session, we have Dr. Viral Jain from Cincinnati Children's Hospital. Viral is a son of the soil from Gujarat, now officer at Cincinnati, and his interest includes to correct whatever is bent, whether it's spine or the limb. So he does spine deformity correction surgery in children, but also he does limb reconstruction surgery. And he's going to present to us a series of lectures on limb reconstruction. And today is the first on limb-length discrepancy. So I invite Viral to start his presentation. So once his presentation is over, we'll have question answers. And I request that those who have questions, please WhatsApp to me on 932032988. We'll flash this once Viral's presentation is over. But keep sending your questions when his lecture is going on so that I can compile the questions and ask at the end. We also have a WhatsApp group, so people can also ask questions on the WhatsApp group, and people can also ask questions on Ortho TV, those who are watching on Ortho TV. So welcome to everyone on the fifth IPT, which is IFICS PDOT tutorials. And Viral Jain, I request you to share your screen and start your presentation.
So good evening, everyone. Thank you for the opportunity. Very excited to be the part of IFICS presentations. So we are going to talk about very basic principles of leg length discrepancy. My goal was to keep in mind the residents, especially the senior residents who would be getting ready to do these surgeries on their own. But this is very basic overview, does not include fancy x-rays or surgical technique. That's probably for later. And there are some things that might be of benefit to the fellows as well. All right. Sorry, let me just go through this. Okay. All right, so there are several compensatory mechanisms that kids would operate on when they have leg length discrepancy. Usually kids compensate better than the adults because they have a higher strength to weight ratio. The most common way to compensate for kids is through toe walking, whether the adults usually vault over the longer side or the shorter side, depending on whether they have arthritis or not. But it does require a lot more energy. When there is a very large leg length discrepancy, they have knee flexion on the opposite side. That's the mechanism to compensate. So traditionally, leg length discrepancy of less than 1 inch is considered insignificant. Minor leg length abnormalities can be noticed when the patient is walking, even if it is less than a centimeter. But usually when it is more than half an inch or 3/4 of an inch, you can notice it easier. It's been noted that more than 5% of leg length discrepancy, which will cause excessive displacement of the body mass and will cause increased energy expenditure. That can cause knee pain in athletes, hip pain in general population. In fact, up to 10% of idiopathic arthritis in the hips has been, the ones which require hip replacement can be attributed to some sort of leg length discrepancy, and up to 40% by anecdotal evidence, the hip surgeons would say that it can be attributed to significant leg length discrepancy requiring eventually hip replacement. This is a biomechanical criteria that has been defined. 1 centimeter of leg length difference equals about 2.5 degrees in change in center edge angle. Now, when you have to remember that when we walk, we don't walk with both the legs on the floor or on the ground. So uncovering of the hip is not an issue when we are walking. It's an issue when we are steady. Spine may cause increased back pain, especially if the leg length discrepancy is significant, and can cause arthritis. Now, the thing about spine you have to remember is that if there is leg length discrepancy, the convexity of the curve, especially in the lumbar spine, that's what you will usually get. It starts with a lumbar scoliosis, where the convexity is towards the shorter side. If you have a convexity in the lumbar spine opposite to the shorter side or on the longer side, that may be actually true idiopathic scoliosis. 95% of our growth in the lower extremity occurs from proximal tibia and distal femur. And as you can see, 9 to 10 millimeters per year in distal femur, and up to 6 millimeters per year from proximal tibia. And that constitutes about 65% of total growth. Now, we have to remember when you are thinking about this growth, these numbers are true for later part of the life. It does not directly apply to when the kids are younger. So I would say as a bet, on the safer side, if the child is about 8 years of age or 9 years of age, you can apply these criteria. Most of our knowledge from for the lower extremity deformities in leg length, especially leg length, is derived from Green and Anderson studies. Started back in before 1950, actually. In this paper, they described a longitudinal study on a single group of children and provided individual leg lengths of the femur and tibia in boys and girls from age 1 to 18. And in a subsequent study, they provided the graph showing the growth remaining, the distal femur and the proximal tibial physis as a functional of skeletal age. So we'll revisit those charts later on. But when we are doing a clinical assessment for a leg length discrepancy, the most common method that we use, which is sort of accurate, is tape method. True leg length discrepancy means discrepancy between in the lower extremity starting from the level of hip to the ankle. Now, hip joint, you cannot actually clinically exactly pinpoint. So as a surrogate, we use the anterior superior leg spine. And because it's not on the center of the hip, the anterior superior leg spine method can result in variation in the leg length measurement depending on lower extremity position, whether it's if it is adducted or abducted. And so it's important for us to have the legs straight when you're measuring it. And typically you measure it from bony prominence to bony prominence. So I usually use it from ASIS to the lateral malleolus. However, I want to say that for the completeness sake or the purity sake, the leg length discrepancy can also happen in just the foot or the calcaneum. And so ideally you would want to measure the leg length from the bottom of the foot to the ASIS. Apparent leg length discrepancy is measured from the midline of the body from a fixed point, either a xiphoid or umbilicus, to the lateral aspect of the foot. Now, in general, when you have two leg length discrepancy in a squared pelvis, both apparent and the true leg length discrepancies should be same. But if these measurements are different, then you have to consider a fixed pelvic obliquity as a factor. Now, in a quick and easy way to measure leg length discrepancy is a block method. As you can see, you ask the child to stand on a block and even the pelvis. The problem with this method is that if they had previous surgeries on their pelvis, or if their pelvis itself is deformed, it's not very accurate. However, when we are measuring, in a clinical way, measuring the leg length discrepancy, you measure all the methods that you have available at your disposal. Radiographic assessment is more accurate. There are several ways to measure this. Teleradiograph is essentially a single exposure of the entire leg, which may be okay for kids who are not too tall. There is a significant magnification error. So you always have to have the ruler and also have to tape an object on the lateral aspect of the midline of the longer axis of the lower extremity. Essentially, you can calculate a magnification factor and then you can apply that. At our place, we do it through a digital way, and so the magnification is already included in the measurement. Even better, if you are just purely assessing the leg length discrepancy, you can do scanogram, which is essentially 3 X-rays of the hip, knee, and the ankle with a ruler. And so you can measure by subtraction method. What we do at our place when we typically use a digital radiograph is what we call as orthoradiograph, where we take 3 shots of the same extremity. The tube moves over the hip, over the knee, or the ankle, and then the computer stitches them up. And this gives you a fairly decent accuracy. You don't have to worry about the measurement, the magnification. The trouble here is twofold. First, primarily, you can't really get a foot height. That is true with any X-ray. So a standing orthoradiograph is the one which you should use. The advantage of orthoradiograph is that you can also assess deformity with this method. So goal of any corrective treatment for leg length discrepancy is to have equal leg lengths at the time of maturity. All these prediction requires calculation of current growth rate of the both shorter and longer legs. And when you compare them together, they will give you an inhibition factor. And then you consider that inhibition factor in your calculation and you predict future or leg length discrepancy at the maturity. So most commonly and easiest one that is being performed, at least in my practice, is growth remaining method. It is an assessment of inhibition where both growth of both legs in a given interval is measured. So that interval typically is 1 year apart. So we see these patients every year, except when they are close to their growth spurt, we probably see them every 6 months. And that gives us number of readings that we can plot or decide, and compare that with our initial assessment of a growth remaining method. So this is the formula. You don't actually have to use this formula. I'm going to show you how to do it with the Green and Anderson growth remaining chart later on. So this is the Green and Anderson original chart for skeletal maturity and its function with the leg length in boys and the girls. It gives you growth percentile. But later on, they published what we call as Green and Anderson growth remaining chart, which is what I typically use as a quick and dirty way to measure or predict rather a leg length discrepancy. So just let's just spend a few minutes on this. If you can see on this side as an example, in a girl, on this axis is the length of the distal femur predicted and length of the proximal tibia predicted. Or in other words, if you were to do a full epiphysiodesis of the proximal tibia or distal femur, this is how much length you're going to lose. So you plot their current skeletal age. So let's say this girl has a skeletal age of 12. You also have these percentile for the growth, and a rough way to measure their percentile for the growth is to use their height record. It's not accurate because the height can change, and it is very variable depending on who is measuring the height, but it will work in a clinical setting. So this, let's say this girl is at 75th percentile or the 2 standard deviation for their height. So you use this dotted line for their growth remaining. So let's say if this girl has a bone age of 12, and we want to do epiphysiodesis and has a leg length discrepancy, let's say 1 inch, you can plot there, and you can see that this girl from proximal tibia has approximately 1.5 centimeters of growth remaining. So if you do proximal tibia only, you get 1.5 centimeters. And then you extrapolate that for the femur, and you can see that if you were to do femur in this patient at the same time, you're going to lose 3 centimeters, almost 3 centimeters of length, which means you're going to get 4.5 centimeters of leg length, growth inhibition on that longer side, which is not ideal. So you would want to wait before you do the femur, and ideally you would want to be at around bone age 13, almost 13 and a half to perform the femur. This is how roughly you will calculate the amount of growth inhibition that you can get on the longer leg. It uses skeletal age, it uses growth percentile. You need at least 2 separate set of graphs so that your prediction is a little bit better. The trouble is that it only takes into account most recent skeletal age when you are measuring it, just for, if you have one reading. And it does not take into consideration the true growth percentile, and it's not applicable, as I said earlier, to children less than 8 years of age. So you use the Moseley's line graph method. This might be a little bit advanced but I think it will be helpful for senior residents and the fellows how to do the growth, how to use the Moseley's line graph method. So on this chart, it's based on the Green-Anderson chart. It's charted differently. The overall leg lengths are in centimeters on this axis. For the girls, the skeletal ages are up here. For boys, skeletal ages are down there. This is a line based on the previous readings from Green and Anderson. This is the long leg line. This represents predicted or expected long leg growth in patients. Now, on this side, you have leg length. All right. And then these are the reference slope for the epiphysiodesis. So let's go through this. Let's do an assessment of how you would plot on Moseley's line graph method. You have to do this serially. So, you see these patients every 6 months or every year and do this every time. And this takes time. So you probably don't want to do it in clinic, but in your office, you want to do it. So what you do is plot the length of the long leg on the long leg line. So essentially, let's say this patient has a 60 centimeter on the long leg. You plot that on the long leg line. And then you draw a vertical line to intersect with the bone age. And then you plot the patient's bone age as well. As you can see, the bone age gets intersected in this area. So let's say this patient has a bone age of 11 the bone age of 7. As you can see there, you plot that dot. Now you see the patient and measure the short leg. Let's say the short leg is maybe, let's say, a little less than 55 centimeters. So this is one reading, one point in time. You use these multiple readings, and let's say next year and the year after. And then what you do is you draw a line connecting the dots on the short leg. And this blue line essentially gives you a prediction of the growth of the short leg. So now you draw a growth percentile line from the skeletal age section, and then you extend this growth percentile line till it intersects with the skeletal maturity line. And then you draw a vertical line down from the skeletal maturity line, which is your growth, end of growth line. So you draw a perpendicular line, a line, not necessarily perpendicular, but I draw a line connecting these dots on the skeletal age, and it intersects with maturity at this stage. You draw a line from there. This portion of this green line is your end of growth line. And the difference between the long leg and the short leg is actually your predicted leg length difference at the time of maturity, as you can see right there. So now when you are thinking about operating on this patient, what is the time when you want to do the epiphysiodesis? Now for that, you draw parallel lines to the epiphysiodesis lines. So essentially, these are the lines which will give you a prediction of slope of the tibia, femur, or if you do both distal femur and proximal tibia. And you draw a line which is parallel to this line, but starts here, starts at your last reading of the long leg. So this line is parallel to the combined epiphysiodesis line, and it gives you an idea that if you were to do a surgery for epiphysiodesis on that long leg, you will still end up with some leg length difference. So this is how we do Moseley's line graph. It has advantages. It takes into consideration true growth percentiles. Multiple readings, however, are required. It can be applicable for younger children as well, but it's very complicated. So in any case, you don't want to do epiphysiodesis in very young children anyway. So Pele came out with multiplier method. It's essentially from the data obtained from Green and Anderson study. However, the age multipliers have been validated in various different populations, and this is currently the easiest way of doing it. They actually made it even more easy. They have an app which is called as multiplier method that is through Mount Sinai Hospital, and you get all these. You don't actually have to plot anything to use multiplier. You just feed the data about the date of birth of the patient. It will give you growth charts. It will give you epiphysiodesis. It gives you all the formulas, and also gives you the physical multipliers as well. So in an example, in a congenital leg length difference, the thing about congenital leg length difference is that the inhibition factor remains constant throughout the life. So multiplier method is very helpful for these patients. As you can see, these are the multipliers, the actual multipliers. So if you were to see a child of 2 years of age, a boy, their multiplier is 2.590. And then you multiply their current leg length difference and multiply it by the multiplier. Let's say if they have a current leg length difference of 1 centimeter, you multiply it by this number, and this gives you an approximately 1 inch leg length difference at the time of maturity. It's very easy. The trouble, however, is when you are trying to do acquired leg length difference, because the rate of growth of both legs change proportionately with age, but it remains constant. The inhibition factor sort of remains constant. However, let's say if patient has a variable type of growth arrest secondary to any condition, let's say traumatic growth arrest, it's better to use the growth remaining method rather than to use a multiplier method. For the acquired leg length difference, it's very difficult to use multiplier method. This is the formula, and you don't actually have to do this. You can put all the numbers in your app and you can get it. So my request to you would be that in your practice, use all the methods that you have for prediction. That will give you an understanding of what exact age you want to do epiphysiodesis on these kids. More readings you have, better it is. So goal of treatment is equal leg length at maturity, because unequal leg length, as we see, can cause weakness in the short leg, and especially in patients who have muscular problems, wearing braces can be cumbersome. The pelvis should be level, ideally, unless the deformity is transiliac. The goal is straight lumbar spine, and you also want to correct associated problems if there are associated with it, especially the unstable joints, as you may find in proximal focal femoral deficiency. So basically, this is what the treatment algorithm that I use: 0 to 1 inch, no treatment; 1 to 2 inches, either you use shoe lift, epiphysiodesis, or you can do shortening, depending on the patient's circumstances, age, and anything more than 5 centimeters or more than 2 inches lengthening. If it is more than 20 centimeters, there is no point in doing lengthening, although people will claim that they have done it. I don't think any necessity of lengthening more than 12 or 15 centimeters is functionally better than an amputation and prosthetic fitting. As far as we are concerned, shortening is always preferable to lengthening. Acute shortening is, however, different. We're talking about shortening through epiphysiodesis. However, if the difference is going to be more than 2 inches or 5 centimeters, I don't think that's a good option. The other thing you want to explain to the family that equal knee height is not essential for normal function. The most simple is shoe lift. It can be used up to 5-6 centimeters, up to 2 centimeters of lift can be put inside the shoe, and then rest of it can go on the bottom of the shoe, and so it's a shoe insert versus shoe lift. The advantage is clinical trial and error. It's not a permanent thing. And you can change the size of the lift as the child grows. So prosthesis, when you are waiting, especially for shoe lift, when you are waiting for the child to become reach to an appropriate age for doing epiphysiodesis or lengthening for whatever reason, and their leg length difference is more than 2 inches, especially close to 3 inches, you want to use an ankle foot orthosis or AFO along with the lift so as to stabilize their ankle. This typically happens in patients with fibular hemimelia or PFFD, where their ankle itself is not stable, and so the brace will help. Children with below knee amputation and prosthesis have almost normal gait and function. You have to remember, you have to start early. Younger the child is, easier it is for them to get used to prosthesis, as we all know. Unconventional prosthesis can be used when the foot is to be preserved for later leg length discrepancy, or if the parental desire is there. So epiphysiodesis is the most common procedure that we do for leg length discrepancy. It is surgical treatment of choice for up to 6 centimeters of leg length. Nowadays, with the availability of precise nail, we limit the use of epiphysiodesis to about 4.5 centimeters or 4 centimeters, depending on the patient's age. You always have to err on the side of undercorrection. So you want to undercorrect by about 0.5 to 1 centimeter. At least 50% area of the growth plate should be removed. However, with the newer techniques, well, these are not new anymore, but with these techniques where we use screws, you don't really have to do that. The screw epiphysiodesis is what I typically use nowadays. The 8 plates can be used for epiphysiodesis. You can put the plates on the either side of the physis. They were not designed for a growth arrest, total growth arrest. They were designed for deformity correction, so I use them only for that. As we talked about briefly, acute shortening, you do not want to do more than 5 centimeters for femur and 3 centimeters for tibia. It's very rarely done nowadays. It has it's a very high risk of complication, delayed union, especially post-operative muscle weakness can be permanent. So that's why we don't typically prefer that. So metaphyseal femoral shortening can be done in closed fashion with the use of a locked nail. Again, the same problems remain. It takes a long time for rehab. Proximal is preferred, but it's more invasive. So this is how you do it. There we used to have a cutter that goes inside and performs the osteotomy in a closed fashion. We don't have this instrument anymore. So it's sort of an open technique nowadays. And we rarely do it. I mean, in the last 5 years, I've probably done one shortening. Leg lengthening is not indicated for discrepancy for less than 5 centimeter. Acceptable growth for a single lengthening is about 6 to 8 centimeters for femur and 5 to 6 centimeters for tibia. If you do more, you can do it. It just creates more problems. Simultaneous segmental lengthenings are required for larger leg length discrepancy. If the difference is more, you want to stage it. Depending on the age of the patient, the lengthening can be performed at between 4 and 6 actually years of age, between 8 to 10 years of age, and 14 to 16. The last lengthening always have to be done after the patient is skeletally mature. Acute lengthening, where you can lengthen the leg fixation with a nail or a plate, and or you can do transiliac lengthening in an acute fashion as well. Gold standard, however, is distraction osteogenesis, developed by Elazarov and popularized by, well, at least in Western world, by Di Bastiani. So when you are doing osteotomy or for lengthening, the typical word used is corticotomy, which preserves medullary contents and understable blood supply. Multiple studies have shown that periosteum contributes a lot more to the regenerate rather than the endosteum. So you can still do osteotomy where you can go with the osteotomy through and through. But you have to preserve the periosteal sleeve, and it has to be a low energy way. So multiple drill hole technique is the gold standard for this. You ideally want to do osteotomy at the metaphysis or corticotomy at the diaphysis. As much as possible, try to do osteotomy at the metaphyseal level, which gives you more predicted regen rate. Never use motorized saw for lengthening osteotomies, please. The number of osteotomy you can perform: double osteotomy at the proximal distal metaphysis to reduce the total length of time in the fixator. You have to be careful to preserve the alignment of the central segment, and you can only do this at the metaphysis. Don't do double osteotomy at the diaphysis. One, because of the obvious reasons. The lengthening has multiple complications, as we will see. Double osteotomy usually performed in femur, not anywhere else. Typical rate of distraction 1 millimeter per day, which is divided in several sittings. Typically use 1/3 millimeter per day for 3 times a day in a precise nail. In a typical external fixator, it's easier to do it 4 times a day. Osteogenesis starts in the medulla and fills the gap, and is similar to intramembranous bone formation. It also increases the vascularity of the lower extremity, in that, and it has been used for peripheral vascular diseases as well. Not necessarily lengthening, but the distraction osteogenesis. For fibula, when you are doing lower extremity tibia fibula lengthening, fibular osteotomy must be performed. Otherwise, the lengthening will not happen. You do not want to do segmental fibular osteotomy, obviously. You have to fix, if you are doing a lengthening 5 centimeters or longer, you want to fix the ankle mortise with a syndesmotic screw, which can be removed later once the length is achieved. And if you are doing a longer lengthenings, let's say 8 centimeters, you want to fix the proximal tibia, transfix the proximal tibiofibular joint to prevent the distal migration of fibular head. There is a concept of dynamization. So dynamization is essentially a cyclic compressive loading at the site of regen rate. And this is at the this can be performed at the time of distraction, but typically it's performed at the time when you are done with the distraction and you are worried about the quality of the regenerate. And one of the reasons why I prefer ring fixator with wires is because the wires themselves are flexible and promotes cyclic loading once the patient starts to bear weight. Monolateral fixators and half pins are more rigid, and they have a mechanism to dynamize built into in current generation of implants. And there are principles that we will discuss later on when we are talking about the details of leg lengthening and how to do that, maybe at a later date, you know, in terms of what the construct should be and how many pins and wires and all those things. So lengthening index is essentially a number of months spent in external fixator or any lengthening device. Number of days spent in the lengthening equals to the number of days spent for regenerate. So let's say if you were to do 5 centimeters of lengthening, that is 50 days. So you would explain to the family that, you know, you will approximately spend 2 months in the fixator with active lengthening, and then you give it at least 2 more months for the regenerate to become strong before the fixator can be considered for removal. And so total duration is approximately 4 months. So in other words, 1 centimeter per month is a useful guide. You also have to think about the axis of lengthening, and we'll talk about that in the technique later on in another lecture. But femoral lengthening should always be performed along the mechanical axis of the femur. And so the shunt spins that you put in should be perpendicular to the mechanical axis, not to the anatomical axis, but to the mechanical axis. So nowadays, almost all of our lengthenings are performed by precise nailing, except for the kids who have considerable leg length difference secondary to fibular hemimelia or PFFD, where they need multiple stages of lengthening, where we have to do lengthening at a younger age. Precise nailing is our to-go instrumentation. It has a lengthening mechanism which is dependent on magnets and gears, which is located in this section of the rod. This is the section of the rod which actually lengthens as you use the magnetic remote controller. And it's a locked nail. It's available for femur as well as for tibia, both. The advantages are obvious as compared to the external fixator. There is no pin track infection. There is no transfixation of soft tissues. It maintains the mechanical alignment and the stability during lengthening as well as consolidation. You do, however, have to look for the mechanical axis deviation in the femur. You can compress by reversing the polarity on the remote controller in case of poor regenerate. You can technically have earlier weight bearing than external fixator. And as of this year, they have a weight sharing rod available as well, where patient can start weight bearing without worrying about the fracture of the implant. It does require removal. It is magnet, and there is a lot of corrosion. So manufacturer has recommended removal. It is theoretical whether the corrosion affects the bone. It's all intramedullary, but at least in our country, it at least needs 2 surgery, one for the insertion, one for the removal, and other surgeries there are problems. Other complications which are unrelated to technique for any lengthening still apply for this technique as well. So this is the external remote controller. They have a second version now, but they have a little, this is pre-programmed by the surgeon, and it will only lengthen 1 millimeter, whatever you have specified. So we specify 1 millimeter per day, and then we do it in 3 sessions. So it will lengthen for 1/3 of a millimeter per day. So you have to do it in 3 sessions. It will not over lengthen. The newer one has actual visible LCD screen where you can actually see what's happening. There are monolateral external fixator systems. We use OrthoFix traditionally. It's a relatively simple apparatus, but it does not allow correction of multiple deformities. It does not even allow angular correction in a gradual fashion. You have to acutely correct the angular deformity. It is a small margin for error, and there are different sizes available nowadays. It's a little bit more flexible, but still has this traditional disadvantages of any monolateral external fixator. Ring fixator is R2GO method for length discrepancy and lengthening for more than 5 to 7 centimeters. You can use Taylor spatial frame where the computer determines these lengths. For the sake of simplicity, you still use a traditional external fixator with Ilizarov technique, as long as the patient does not have multi-planar deformity. This disadvantage is obviously it's very cumbersome. It's less acceptable to the patients, and in our country, it's more expensive or almost as expensive as precise nail, if you consider the problems associated with this apparatus. So every lengthening is going to be associated with significant complication. They are so common that they have been classified into problems, obstacles, and complications. Problems are difficulties that require no operative intervention, obstacles that does require operative intervention, but it does not change the final outcome. The complications are defined as things that happen that will cause permanent damage and compromise the ultimate outcomes. Late complications can also happen, especially the refracture. Pin track infection is the most common problem, and it can be avoided by careful pin insertion technique and pin care. It's not always avoidable. I usually do not, it's been recommended that you should clean with antiseptic material. I typically don't, once the seepage is over, I typically don't disturb the pin skin interface by daily dressing. I just cover it with the dressing and let it be, so that the skin or the epidermis heals around the pins. That has considerably reduced my rate of pin track infection. But you have to be aggressive. You have to be ready to prescribe antibiotics and IND if necessary. Muscle contractures, however, are the biggest issue that I have seen in my practice. Even with the precise nailing, this complication cannot be avoided. And they are most difficult to treat. Vigorous, frequent physical therapy is crucial. We actually start these patients on a dummy physical therapy of 1 or 2 weeks prior, so that they understand their goals and understand what they really need to do. So your foot should be in fixed neutral position if you're going to do a tibial lengthening of more than 5 centimeters. You can, with an external fixator, you can easily do that. With precise nailing, it becomes really hard. And that's the most common problem that I've seen in my practice is ankle or the tendo Achilles contractures. Joint contractures, if they are more than 20 degrees, will not respond to PT typically. You have to either stop distraction, do manipulation, or employ some release technique. So that's another surgery. And that's the reason why we want to be ahead of in the game and don't let them develop to start with. Joint subluxation and dislocation can occur. That's very common, especially in the patients with PFFD or fibular hemimelia. When the joint itself is unstable before surgery, it's recommended that you transfix, you stabilize the knee joint when you are going to do a lengthening. It's easy with an external fixator, not so easy with precise nailing. So you have to be very careful of those joints. You want to evaluate those joints. it can be treated by a circular external fixator, which is what I have typically done to correct the subluxation. Neurovascular complications are permanent. In acute, usually are related to faulty pin placement. Compartment syndromes can happen in tibia. However, keep in mind that you are doing an osteotomy in creating a fracture with a considerably low energy as compared to a traumatic fracture. And so the risk of compartment syndrome, even though it's there, it's lesser. But as you distract, the compartment do become tight. So typically when you are doing it, especially for tibia, when you're doing this osteotomy, you do prophylactic fasciotomy. It doesn't change. It just takes a few more minutes in your surgery. Some for the longer lengthening, it's been recommended that you should do peroneal nerve decompression, especially around the proximal fibula. Premature consolidation is usually caused by an excessive latency period. In femoral lengthening in children, latency period of 5 days, tibial lengthening is 7 days. Older the child, longer should be the latency period. Typically, the premature consolidation that happens, we've seen it in fibula more than in tibia, of course, and that will result in inability to distract tibia because the fibula is now consolidated. You can overpower early premature consolidation by doing a sort of an acute lengthening in the clinic, where you lengthen acutely for about 1 centimeter, and you may sometimes feel a pop where they regenerate in sort of fractures. If you are worrying about the increased density at the regenerate site, then you should speed up your distraction. Delayed consolidation is more common with diaphyseal lengthening than the metaphyseal corticotomy. It is more common in tibia, and most common contributing factors are either frame instability, or at the end, if the frame is too rigid, if you do too rapid distraction, or you start distraction too soon. Distraction can be slowed or stopped, and bone can be compressed, or bone can be alternatively compressed and lengthened, and which is what is called as accordion method. Bone grafting is the last resort that you have to do. Refracture does happen. It is more common with fibular non-union in the case of tibia. It can also happen with a premature removal of the frame. You can treat it with casting if it is undisplaced, or typically you have to reapply the external fixator. The refracture rate is high in patients who have had external fixator lengthening as compared to, of course, as compared to intramedullary lengthening with precise nailing. Since precise nailing is the nail is not taken out from the bone for at least 1 year after you're completely satisfied. So I have not seen refractures recently since I've started using precise nail. The other complications include chronic pain, and that is fairly common, at least in our patient population. Usually the older the child is, or in other words, older the teenager is, higher is the risk of chronic pain. There is a way you can assess. We don't do this routinely, but you can also, when you are assessing the patient before the surgery, for leg lengthening, especially with external fixator, but for any leg lengthening, we usually do, we don't do it, but it's recommended that you should have, if you have red flags, let's say the red flags are typically pre-existing pain condition. In our patient population, Ehlers-Danlos or soft tissue laxity is associated. It's fairly common, and some of the Ehlers-Danlos types are associated with chronic pain. So if you encounter those patients, ideally you shouldn't lengthen them, but if you have to or you're forced to, They have to undergo a psychological assessment, and we also have to sort of predict what kind of pain issues they will have later on. Now, when you are doing distraction, and the patient sometimes will complain of pain along the distribution of a particular nerve, that could be because of too fast of a distraction, or if it could be secondary to neurological compromise. So that's a neuropathic pain. So you have to be careful about that. So there was no pain at certain point in time, up to certain point in time, and then suddenly starts to have gradual worsening of the pain in a nerve's distribution. That's a neuropathic type of pain. The other pains are related to either fracture at the spin site or associated with infection, or if there is premature consolidation and you're trying to distract, especially with the external fixator, you can have pain as well. So this is where I would like to end my presentation. And then there are a number of things that happens in Lakeland. We haven't talked about the specific syndromes. We would like to talk about deformity correction and the principles, especially the principles. We hope that we can get it done in the upcoming series.
So thanks, Viral. That was, complete and exhaustive. We have some questions from the audience. And before that, from the floor, are there any questions? Premal, Chintan, you want to ask any question? And then I can go to audience questions. Premal, you'll have to unmute yourself. Yeah.
Yeah, sorry, Viral. How often nowadays do you do epiphysiodesis, as you admitted? Because in India, we have a shorter height. So very few patients are very keen on getting themselves short because they're already a little short. So
yes, I think that's an issue. I do occasionally find, especially in girls who are not of Caucasian descent, they would not prefer epiphysiodesis. But by far the most common, I mean, we do a bunch of those epiphysiodesis. The thing I think is that at least what I've done is that let's say if you see a patient, with 6-7 years of age, that they're going to need epiphysiodesis. I see them every year, and every time we talk about, epiphysiodesis as better. It's still, as I said, height is not an issue in our patient population for most part. But there are techniques that I have employed to sort of try to convince those patients. But at the end of the day, precise nailing is getting better, and it's easily available for our patients. And that's why I said, previously we used to do lengthening for leg length discrepancy more than 6 centimeters. That has gone down to about 4.5 centimeters. And the patients who are well educated and well informed would actually come specifically for this particular issue. And I have had several families who I talked about doing epiphysiodesis when these were all boys, when they were 12 or 13 years of age, and they essentially disappeared. They didn't come for follow-up, and they came back at 17 years of age because now they were ready for a leg lengthening. And so it's difficult. That's all I have to say.
Right. So since we are on the topic of epiphysiodesis, between the 8 plates and the screws, what's your preferred method?
So the best treatment is to not leave any hardware in patient's body. So, McCarthy, who is our division chief, he just does drilling. And, for most part it works. I usually use the percutaneous screws because I'm still worried about whether the drilling is going to work or not, and how much growth plate we have to remove. But I mean, you can use it interchangeably. The 8 plates, I have had issues with them. It causes, first of all, it takes longer time to start the growth inhibition as compared to the screws. And if you use it in a very young child, while even with the screws, but it can cause permanent physial, actually not permanent, a deformity in the physis. The screws can cause it as well. And so, so on the younger child, we sort of, there is not a clear-cut answer. It depends on the surgeon preference. But if the child is skeletal age of 11 or 12, we just use screws.
And how long would you keep those screws maximum? So you're using
I
the method.
typically don't take them out unless we are forced to, if there is a, over shortening. Otherwise, I keep them in forever.
Right. So you would decide the timing of the epiphysiodesis same as a permanent epiphysiodesis, and use screws
Correct.
instead of open methods.
Correct. Then, of course, if the child is less than 10 years of age and for some reason, and there are families who would prefer to do epiphysiodesis versus lengthening, because at a younger age, if they have considerable leg length difference, if of more than 1.5 to 2 inches, or more than 2 inches, is going to be hard during those years when the patient wants to wait for the appropriate timing for epiphysiodesis. In those cases, we do screw the plate epiphysiodesis and then take the plate out in about a year and a half.
So, Viral, when did you use the Mosley's chart last?
Mosley's? Well, my last lengthening was 3 weeks ago. That's when I used it before that, but that's how I planned.
So you use the charts and not the
cumbersome, but if you have patients who are reliable coming back every year, it works very well.
Right.
So I'm just reading.
So what is the earliest age for limb lengthening?
Earliest, I would say 4 or 5 years of age. And the reason why I put those numbers is sort of, it's not essentially scientific, but it's more social as well. In US, kids usually start kindergarten at age 5. So if you want to do a lengthening, their first grade is at age 6. So if you want to do lengthening, you want to do that before they enter in school. And so that's and also I would like them to be a little bit older as well. So at least we can handle their limbs in a little better fashion. So that's why it's 4 or 5 years of age. Up to 6 years is considered okay, depending on their social situation. The second phase, you don't want to do anything between 6 to 10, 5 to 9 years of age, depending on the whether it's male or female, because especially boys are not mature enough to handle the external fixator, at least in our population. So that's why the second phase is between, approximately around age 9, 10. And as I said, it's not scientifically related, it's more social factors. So it can be different for another patient.
Okay, Viral, I'm going to put you through some situations, and I want short answers to these big troubles which we face during limb length disturbance. The first situation is that you are doing tibial lengthening and you started distraction, and after 4 weeks there is no regenerate seen on the X-rays. How do you address that?
So you want to stop lengthening at that time for about a week, reassess the situation, think about that your radiographic regen rate is going to be about a week behind. So you may still be okay. If you see regen rate worse, at the end of 1 week, then you can resume. If you don't, you still want to wait. And it also depends on age of the patient as well.
Do you ever give alendronate, bisphosphonates to improve your regen rate?
I have not typically used it.
And would you do ultrasound or do any investigation help you to find out if your region rate is adequate, or you would rely still on the X-ray?
Well, at the end of the day, what we really need is, at 1 centimeters, I don't know if the ultrasound is going to give us a great picture, but let's say if we were at 4 centimeters and we are worried about region rate, I think all of our criteria for further distraction is typically based on X-ray. Ultrasound may show us continuity, but I don't know if it's that reliable.
The second situation is you're doing femur lengthening, and this child, though was on a physiotherapy, was told exercises. Notice that at 3rd week has developed 20 to 30 degrees of knee flexion deformity, and it's progressive, and now knee is developing subluxation. So how will you address that situation?
So I think that's a contraindication for lengthening in my case, and I unfortunately have had several patients that I actually essentially told the family that I cannot go further. And so essentially at that time, you stop lengthening. I have used circular fixator to gradually get some distraction. You're talking about 2 or 3 millimeters of distraction along the knee joint, and pull the tibia a little bit forward and slowly correct their deformity. And then that's it. Let the bone heal, take the fixator out, let them do their physical therapy, and hopefully in a couple of years they will be a little bit better. But you don't continue with the lengthening for that patient.
So Viral, what we do nowadays is I generally use a monolateral fixator for lengthening for femur generally. So what I generally do is I make a long leg splint, which is basically full straight splint. So you splint a child every night, so that every night the hamstring gets stretched. And since I've been using this for almost now 7-8 years, we haven't had a single case of even 5-degree flexion deformity. So
and yes, and that does work. And a lot of our patients will use that when they are doing, we have a special specialized physical therapists who take care of more lengthening patients than the regular patients, and we send them to them. And in our setup, of course, everything is decentralized, so the physical therapists use those nighttime braces.
Because here, our patients go in hinterland and they don't have access to even basic dressing.
Correct.
So physiotherapy is
right. No, you're right. And there are ways they can do stretching exercises, and there are, of course, we used to do them when we were in residency. So
yes, Taral, you were saying something.
Yeah, question is, yeah. So would you extend the frame if you're doing femoral lengthening? Are there indications to extend to tibia end?
Yeah, so if you're doing femoral lengthening for, again, age, you have to keep in mind the age. But if you're doing it for more than 5 centimeters, I extend the frame to include the proximal tibia, especially in a younger child. And in a tibial lengthening, again, it's the same number, approximately 5 centimeters. We usually like to put the foot, I used to do that in the residency. We used to do that in the residency in my practice in India, where you you create a sling out of a rubber and hook it up with the frame. And I have a sort of a cheap and dirty version of that for my patients here as well. And a number of systems that I use have built-in sort of sling type mechanism for those patients. So even for those patients who require up to 5 centimeter of lengthening, use the sling. If it is more than 5 centimeters, we extend it and include the foot. Especially true for fibular hemimelia. I almost always use a foot frame for them.
Okay, question.
Can I ask a question?
Yeah, please, Sandeep.
So if you lengthen over a nail with a rush nail inside the medullary canal, that's one of the techniques to give some additional stability. I've always found the
Sandeep, you are not audible, I guess.
So I think the question he was trying to ask you is if you use
The
a
2
rush
millimeter
nail,
thin rush nail
so the regenerate is
with the
not of good
LRS.
quality.
It's not of good quality. It's very
Uh,
thin, tapered, and it hardly is seen. But when there is no nail, the medullary regenerate looks much decent.
And
I have had to bone graft a lot of these.
So Sandeep, I have a very contrary view because I never lengthen without a nail inside nowadays, unless there was some old lengthening in which the canal was blocked. As the only indication, I don't use intramedullary nail. So I haven't had that occasion. So our all lengthening
Viral,
is
what is
approx.
your opinion?
I've done it 50-50. I've been, started doing it without the nail. And then in some patients, I've seen that they start to drift and have deformity. And so my indication to do nail would be to avoid a deformity and to feel better that, even if you, for some reason, prematurely take the fixator out, you still have some intramedullary support. The trouble is that the patients that I had used the nail, they had considerable leg length difference. So now the intramedullary nail, medullary nail becomes an
Short.
issue after we have precise nail. So I don't know if you probably already know that they are coming up with a plate which can be lengthened with a remote controller. So I think I'm looking forward to that. And that will take care of a lot of our problems in young kids where you can't use the precise nail.
Okay.
so what plating after lengthening? Are there any patients that you're doing lengthening with an external fixator? And to remove the external fixator, you put a plate and remove it early.
Yes, and I have not a lot, couple of those patients where I did lengthening. The regenerate was, taking long time, and so I had done like a biological plating, which essentially a MIPO technique, just slide the plate over the femur and lock it proximally and distally, and it has worked for me. So so that's another tool that you can use.
Yeah. So any other questions?
So do
I have
you do a
one last rapid fire
iliotibial
round,
band?
but before that,
Sorry.
yeah. Go ahead, Sandeep.
Yeah.
Yeah.
When you do a femoral lengthening exceeding 4 to 5 centimeters, the lateral fibrous IT band sometimes can act. I've seen a patella subluxate. So do you do a lateral release, or
Yeah.
is there some way of tackling that?
No, it's just like
So is the
prophylactic lateral release with all these patients.
You do it all the
Even if
time.
it is less than 5 centimeter, I still do it. It's right there. That's where you're going to make the osteotomy anyway. So
Okay, because otherwise the IT band just pulls the patella off.
yes, and it also causes more problem, and it acts as an deterrent when you are doing
Deterrent.
lengthening. Especially if you can't put a very rigid monolateral fixator in a younger child, you will see that your pin will start to diverge or bend.
for
Thank you
botulinum
very
toxin,
much,
going on similar
Dr.
to relax
Tara.
the muscle.
So question is, do you ever use botulinum toxin to avoid contracture and make the lengthening easy and fast?
Not really. I have not personally done it. I know some of my partners have used it, but they don't use it routinely. So I don't know exactly what the specific indications are.
So any tips on pin track infection avoiding? You did deliberate on that, but little bit more specific.
Yes. So essentially, you want to, once you make first of all, you make the incision when you are putting the pins, you're putting the shunt pins, and not and then you suture the skin around the pins, and usually initially they will drain, so you want to change the dressing. You can use hydrogen peroxide or betadine or whatever else you can use, but eventually when the drainage stops in 7 to 10 days, I have gone away from doing a routine pin care, which was the protocol at our place, to clean it every day with a Q-tip, and then poke it in and clean it everything. I have stopped doing that, and I've allowed the skin to heal around the pin and epithelize around the pin. Now, once you start seeing drainage from the pin, don't be shy on prescribing antibiotics. You can probably take care of the soft tissue infection right away once you start seeing either redness or pain or drainage. So you can avoid a visit to OR for an IND. I used to use those rubber caps for the Elizarov type pins. I used to use rubber caps so that you can minimize the movement between the pin and the leg when the person is doing exercises. And it sort of works as well. But I think the most important thing is once the bond is formed, not to disturb it.
So Viral, if you have deformity and leg length discrepancy, then what's your sequence? Is it deformity correction, then limb lengthening, or limb lengthening followed by deformity correction, or you do it simultaneously with a Taylor's frame or something?
All of those. So if let's say if it is a teenager or almost an adult and has a deformity in the distal part of their femur, you can use the precise nail to correct that deformity. If they have a large, multiplanar deformity, you can still do it within a certain range. If the child is younger and you're going to use the frame or a fixator, you can slowly correct both of those. Taylor spatial frame is, as of right now, is my to-go way of doing it. But if it's a uniplanar deformity, you can use the Elizarov frame and the hinges appropriately, and it's less complicated. I personally, for me, Taylor spatial frame is too complicated.
Okay. Any other questions?
So, Viral, do you ever use hydroxyapatite coated pins?
Almost always.
Almost always. Okay.
Yes. Oh yeah. So I should have said that's the other reason why, that's the other way to avoid pin track infection. Because there is no motion between the bone and the pin, and the motion between the soft tissue and the pin is what's going to cause infection eventually because of the skin necrosis. So the other little things is, try to plan properly your incisions and don't leave the skin tented. Avoid pressure on the skin because that necrosis will eventually cause infection.
Thank you, Dr. Jain, for your question, for your presentation. I want to ask if you've had any challenge with the social question. The patient comes with a shortening of 3 centimeters, but the patient does not want, the parent, they don't want the child to be shorter. They want lengthening. What do you do in that situation? Thank you very much.
It's still a challenge. I don't know the correct answer, but you ask them to come back. Few months later, you explain your position. You ask them to come back, and then few months later, see if they have changed their view. I would, I'm blessed that I have 2 other partners who do lengthening, and they are, nationally renowned. So I would send them, send the patient to them as well to reaffirm that this is the way to do it. Honestly, I don't think it's ethical to do lengthening on a patient who has 3 centimeter leg length difference, honestly. But it's a difficult problem. I don't know the exact way of dealing with it.
Okay. Any other questions? So That was near complete session on the limb length deficiency. There was no deficiency at all. You covered the assessment of the patient, the clinical assessment, the radiological assessment, different types of X-rays, and the treatment strategies. Will not enter in your shoe race when you will do a shortening, epiphysiodesis, and when you will do length, and when you will do amputation. So applications for a postgraduate student, so they can make a decision making. I'm going to put you through a small rapid fire question before we end this session, and you're okay. So choose multiplier or graphs for assessment.
I'm sorry, I didn't hear that. Sorry.
Multipliers or charts. Yeah. Multiplier method or charts for initial assessment of the patient.
The growth remaining method.
Growth remaining method. Fixator or monolateral fixator?
Femur monolateral, circular fixator for tibia.
A child with 5 centimeter limb length discrepancy, growth motion or lengthening?
I'm sorry, 5 centimeter leg length discrepancy?
Lengthening or epiphysiodesis?
In femur. Lengthening or
lengthening.
Fibular hemimelia with 10 limb length discrepancy, amputation or lengthening? What would you choose?
You said 10 centimeters?
Yes.
Well, depending on their age, if they are older, then lengthening. If they are younger, then amputation.
All right. So thank you, Viral. That was a splendid session, and there are almost more than 1,000 viewers for this webinar from India. Dr. Badruddin has been from Nigeria, and he's been, and a lot of people watching this on YouTube. Neeraj,
Yes,
can you,
closing remarks?
tell us the official? Yes.
Yeah. So almost 1,200 people watched this live, and there is always a rewatch thing. People who have missed it will watch it through the night or by tomorrow morning latest, at least 20% more. So thank you, Dr. Viral Jain, and good morning to you, and good night to all of us.
Yeah.
Good night.
Thanks, Viral.
Stay
Bye.
safe, stay in the
Real fun.
house, stay indoors.
I think we all need to do the same.
Right.
Okay.
So Sheetal is here. Sheetal, thanks for being a proxy server. You've been watching this diligently.